important topic. Reason being, as the NICU docs, we're not called to every delivery. So, deliveries can happen in the middle of the day, and we're not called to them because it's a healthy baby. So therefore, we don't know when a baby's born, and we can't review all the prenatal records. Not only that, but the maternal history that's important in the health of the baby. So again, it's not just prenatal labs, but it's also some certain things in the maternal history, which I'll go over. And you guys are kind of the first line of defense. Some of these things are time sensitive. And because it's a healthy baby at that point, and we will not be able to review the history right when the birth happens, sometimes some of these things might be missed. And that's why I feel it's important for you guys to know all this stuff. All right, so let's begin. So let's begin with case scenario. And I would like participation, okay? So we have a 38 and 2/7 weeker presents to labor and delivery on Saturday. Prenatal care was done in Alaska, and they just moved here. The plan is to acquire prenatal labs on Monday. Infant is delivered vaginally with APGARs of 9 to 9, healthy baby, but has this significant nasal discharge, thought to be just amniotic fluid. The infant is transferred to Well Baby Nursery and discharged after 2 days, or sometimes this particular case, they could be discharged in 24 hours. And this is a picture of the discharge. Can anybody tell me what that is? It's not amniotic fluid.
Is that any herpes zoster?
No, but you're thinking along the right path. It is infectious. So it is it's syphilitic discharge. Okay? The snuffles, I believe it's the term is. So the RN who took care of a mother and infant in labor and delivery returns to work at the end of the week with this. Does anybody know what that is? So that's a chancre. That's a syphilitic chancre. That person just got herpes. They had a paper cut. They handled the baby without gloves. They didn't know it was syphilis. They didn't know that this discharge is full of spirochetes. It's full of the syphilitic bacteria, and it entered their wound, and now they have syphilis. Okay. Another case, same case, 38 and 2/7, prenatal care in Alaska, good APGARs, transferred to Well Baby. Parents refuse the Hep B vaccine. Happens a lot, right? Happens a lot, but we don't have prenatal labs, so we don't know if this baby or this mom had hepatitis B or was a carrier of hepatitis B or not, okay? A year later, infant has easy bruising, abnormal coag profile, and hyperbilirubinemia, and is admitted to the PICU and eventually dies of liver failure. What happened? Anybody know? Well, I mean, it's pretty straightforward, I think. Mom did have hepatitis B. Baby became a carrier, eventually developed liver failure, or possibly liver malignancy, and died of liver failure. And we missed it. We could have given Hep B vaccine and hepatitis B immune globulin, HBIG, and dramatically decreased the chance of transmission, and we missed it. All right, another case, same case. In this case, parents refuse erythromycin eye ointment. This is the baby's eyes. What happened here?
Gonorrhea in the eyes.
It's gonorrhea in the eyes. Yep, and this baby could develop corneal ulcerations and blindness, or gonorrhea sepsis, and that's not good. So routine prenatal labs, HIV, RPR, or VDRL. And if any of those things are positive, then you move to a free treponemial antibody. So sometimes we'll see syphilis, IgG, and IgM, right? Hepatitis B surface antigen, gonorrhea, chlamydia, PCRs from the mom, HSV, or GBS. And that's a separate presentation that I have specifically dedicated to GBS and early onset sepsis. Other things that are important in maternal history, we don't see it a lot, but TB, maternal thyroid disease, which is missed alive, maternal lupus, Zika, which is becoming less important, it seems now. And we'll talk about some breastfeeding contraindications as well. So HIV, the risk of infection for an infant born to an HIV positive mother without any interventions to prevent transmission is about a quarter, 25%, okay, in the US, 1 in 4. If it's a controlled maternal viral load, it's less than 2%. So how is a newborn exposed? It's usually during birth, during exposure to mom's blood. What if the HIV in mom is unknown and not declined? We got to test the mom. We have to know, unless she's declined testing for whatever reason. Their state laws can differ based on this. What are the risk factors? If mom has a high maternal viral load, so if we have an HIV positive mother, that's always what I'm going to ask, or a maternal CD4 level below 200, but usually we have a viral load. Transmission to infant has, however, been documented across the entire range of viral loads. So low viral load, high viral load, transmission can still happen. Another risk is newly acquired HIV, like during the last trimester, or if there's prolonged rupture of membranes, choreo, they're preterm, or if they had a fetal scalp electrode. Okay, and that makes sense, right? Blood-to-blood transmission. What do we need to do after birth? Bathe the infant of maternal secretions. And I feel like that has not, especially with the last one we had, that bath didn't occur for hours. And actually, I was the one to have to catch it in the morning, realizing the baby didn't have a bath. So it happened at like 6 to 8 hours, okay? What do? We get HIV or RNA DNA PCR from the cord. Sorry, I think my Alexa is talking. So what do? We get HIV DNA or RNA PCR from the, not from the cord. Actually, the cord blood's not acceptable. We get it directly from the baby, okay? We get a baseline CBC, and this baby needs to be started on antiretrovirals, specifically at least zidovudine, AZT, within 8 to 12 hours. And this continues on for 6 weeks, okay? So bathe the infant, get an HIV DNA PCR baseline from the baby directly, get a baseline CBC, and start zidovudine, at least zidovudine, right away, AZT. What if the mom has a high maternal viral load and or has not had any antiretroviral treatment? This baby may need a 2 or 3 drug regimen, including nevirapine and or lamivudine. And we may need to call infectious disease at this point, because I think now they're asking for us, if there's a complicated case like a mom with poorly controlled HIV, they ask for us to call them. Both the mom and the baby need meds before leaving. So we need to have the baby's meds at the bedside. I think we have a liaison from Juniper Clinic who will make that happen, okay? But before leaving, the baby needs the medicines at the bedside, and the parents need to know how to give it, okay? Any questions about HIV? All right. Syphilis. Okay, just like the first case we had. So if untreated, cases of maternal syphilis, up to 40% of the pregnancies result in spontaneous abortion or stillbirth and death. How is the newborn exposed? Transplacentally, through the placenta. And what are the sequelae? Copious nasal secretions, like we saw earlier, hepatosplenomegaly, brain hemorrhage, pneumonia, chorioretinitis, osteochondritis, a whole host of things. They can have anemia and fetal hydrops in utero and die in utero, or die after being born. And this is just an example of a syphilitic rash in a baby. They have palms and soles, like peeling of the palms and soles there, okay? And these rashes do contain syphilitic bacteria, so they're highly infectious. And here is just kind of an example of all the sequelae for a baby. Hydrops in the top left corner and death, hepatosplenomegaly, necrotizing funicitis, an infection of the umbilical cord, many things, bone abnormalities. And if not treated for the baby later, they can develop late congenital syphilis. And these are permanent sequelae, permanent permanent deformations of the face, of the bone, of the brain, resulting in hydrocephalus, seizures, deafness, mental deficiency. So this is a permanent thing if we don't catch this. Okay. Any questions about that? All right. So what do we need to do after birth? So RPR and VDRL are non-specific tests, meaning they can be positive in other diseases like autoimmune diseases. So if a mom has a reactive VDRL or RPR in pregnancy, and these are different tests, okay? A syphilis specific test is needed. So that's when we go to specific treponemal or syphilitic antibodies to test directly for syphilis, okay? And I think well, maybe some OBs are going just directly to test for that now. If syphilis is confirmed, a pregnant woman must be treated with penicillin and penicillin only, at least 4 weeks prior to delivery. Okay, so they need a full course of 4 weeks, yeah, I think it is 4 weeks, but at least 4 weeks prior to delivery does the treatment need to be. So meaning if a mom started treatment a week prior to pregnancy, that's not enough. And the baby, we may need to worry in the baby. So when do we worry? If the titer, if the RPR VDRL titer in the mom does not decrease fourfold, or in the baby fourfold. So for instance, if the mom had a titer of 1 to 32 in pregnancy, was treated and it did not decrease to 1 in 8 or 1 to 1 or 1 to 4, then the disease has not been treated well enough, okay? So again, when do we need to evaluate these babies? Untreated maternal syphilis, treatment with a non-penicillin, treatment less than 4 weeks before birth, treatment without an appropriate serologic response, meaning a fourfold decrease in the RPR or VDRL. And of note, if the disease has been monitored by, say, a VDRL, you cannot use RPR later. The tests are different. So if you're using a VDRL to monitor the treatment, then you need to use a VDRL later to see how the titers decrease. Does that make sense? RPR, stay with RPR or stay with VDRL, okay? Or of course we have a symptomatic neonate. So what would happen if we were worried about the baby? So we have to admit to the NICU, get an RPR VDRL from the blood, from the CSF, meaning a lumbar puncture, get syphilitic antibodies, get a chest x-ray, long bone x-rays, get liver function tests, an eye exam, and the baby needs to be treated with penicillin for 2 weeks, 10 to 14 days, okay? So it's serious, all right? And oftentimes, this is the one thing that seems to be missing the most, I would say, like an RPR or some kind of syphilis-specific maternal prenatal lab. So it's not a big deal. Like we need to know this, and we need to know whether or not we need to admit the baby to the NICU to prevent late congenital syphilis or not. Okay. Any questions about that?
I have a question, Dr. Lee. If mom was allergic to penicillin, what would be the other alternative for treatment?
So I believe they do desensitize them.
Okay.
I do believe unless there's something new, a new way that they do it. I think they desensitize them and then they treat them with penicillin. Yep. Anything else? So it's a nationwide problem. Congenital syphilis cases rose by 261% from 2013 to 2018. Why is that the case? Well, we think there were a lot of missed opportunities. Lack of adequate treatment despite timely diagnosis, lack of timely prenatal care, late identification of getting the disease in pregnancy, a seroconversion in pregnancy, lack of syphilis testing despite timely care. And there are demographic associations, maybe pointing to an inequality of care. So non-Hispanic Blacks, Hispanics, and non-Hispanic whites. So more so the case in non-Hispanic Blacks and Hispanics. So it behooves us to be much more aware of this. So there's a specific study that looked at 66 cases. 83% had prenatal care. 26%, a quarter, had a syphilis diagnosis in pregnancy. but 42%, almost half, not diagnosed until after pregnancy. So they got syphilis sometime between that first test and the next test after pregnancy, and it could have been during pregnancy. And another quarter had an initial negative test during pregnancy, like whatever it is at 28 weeks, and seroconverted in pregnancy. They got it in pregnancy after that, okay? So what was wrong here? Maybe two factors: inadequate adherence to screening and treatment guidelines, and failure to identify women for whom repeat screening might be a good idea at 28 weeks. So we must be vigilant in reviewing prenatal records and advocate for maternal testing. Some advocate for testing at delivery, even if tested at 28 weeks in certain syphilis endemic areas. Okay. All right. Any final questions about syphilis at all? All right. Hepatitis B. So less than 1%, 0.8% of pregnant women are hepatitis B antigen positive. The greatest transmission risk is at birth. It does cross the breast milk, but it is low, a very low amount. Why do we worry? 70 to 90% of newborns will become chronic hepatitis B carriers if mom has disease with a high viral replication. And the later complications can be devastating, as we saw in our second case: liver cirrhosis and liver malignancy. What do we do? Well, hepatitis B vaccine is the most effective method to prevent hepatitis B transmission. And when we get families who refuse the hepatitis B vaccine, that's maybe a line you can use. Are you sure about that? Hepatitis B vaccine is the most effective method to prevent hepatitis B transmission, not just now, but also later. For full-term infants, there isn't any contraindication, but if it's 2 kilo preemie, which most of you won't have to worry about, we usually give it at day of life 30 or discharge, whatever comes first. What do we do if mom is hepatitis B antigen positive? Baby needs hepatitis B vaccine and HBIG within 12 hours at different intramuscular sites, meaning one leg and the other leg, different legs, okay? Because the immune globulin could interfere with the vaccine, okay? So if less than 2 kilos, this immunization does not count on the normal 3-dose schedule. So if it's a less than 2 kilo kid, they'll get 4 total shots in their first year, okay? Their first 6 months. What do we do? Well, again, hepatitis B vaccine is 75 to 95% effective in preventing transmission if given within 24 hours of birth, okay? If you add in HBIG, the transmission decreases to 0.7 to 1.1%. So then 99% effective, 98 to 99% effective. The Immunization Action Coalition reported greater than 500 hepatitis B history errors from 1999 to 2002. There was either no maternal hepatitis B antigen result, it was misinterpreted, it was falsely negative, or it was reported to the care team incorrectly. Okay, so trust but verify. And you're given a report, oh, this is all negative. All the prenatal labs are negative. But then you look into the chart and it's a different story. So trust but verify. Hepatitis B vaccine given within the first 24 hours is our safety net to miss. So even if the transmission rate, we decrease our transmission rate to 0.7%, that's not zero. There might be a kid who we miss the history and don't do all the things we need to do, and they get hepatitis B and they die during their childhood. So if mom's hepatitis B surface antigen is unknown, test the mom's stat. We should give the hepatitis B vaccine to the baby within 12 hours in that case. And if the kid is less than 2 kilograms, we should give HBIG within 12 hours. If they're more than 2 kilograms, we have a week, okay? So we should have a higher sense of urgency with a kid less than 2 kilograms or close to 2 kilograms, because we could lose weight and drop below 2 kilograms. Any questions about hepatitis B? Okay. Gonorrhea. So how is it transmitted? From vaginal secretions. It can result in neonatal conjunctivitis, for which we give the erythromycin eye ointment to prevent, and that usually happens within first 2 to 5 days. And it results in a profuse bilateral purulent discharge, and then corneal ulcerations and blindness. There can be systemic illness, however. It can result in pneumonia, sepsis, meningitis, osteomyelitis, etc. And chlamydia is commonly concurrent. So that's why they test for gonorrhea and chlamydia at the same time. Again, that's what it looks like, purulent, okay? Erythromycin ointment or 1% tetracycline is used to prevent the conjunctivitis. It decreases the incidence of that conjunctivitis from 10% to 0.5%. But the erythromycin eye ointment does not prevent chlamydia conjunctivitis, which we'll talk about in a little bit. If we see conjunctivitis, treatment is emergent. We need to copiously irrigate it with saline and give 1 dose of either IV or IM ceftriaxone. Now, this is just for conjunctivitis. If it's sepsis or meningitis, it's a way different story. So baby still needs to be admitted to the NICU, even with just conjunctivitis. We need to confirm or rule out sepsis with a blood culture and meningitis with a CSF culture. And of course, we'll get eye cultures too to confirm it's gonorrhea. And this baby would need to be treated if it's just sepsis without meningitis with IV or IV ceftriaxone for 7 days. And if it's meningitis, IV ceftriaxone for 14 days. In terms of chlamydia, if a mother has chlamydia, a quarter to over 50% of infants could be infected. The transmission is again from vaginal secretions, and the conjunctivitis usually presents on day of life 5 to 14. So usually after that baby's been discharged from the hospital. Could be earlier, however, if there's been prolonged rupture of membranes. It's initially watery and it then becomes permanent later. So that's the difference. And the conjunctiva can be swollen red and thickened. And then they can have pneumonia, late pneumonia, a month later, 4 to 12 weeks later. And this is what it looks like. It's more watery at the beginning. Okay, and it's important for the pediatrician to know, like for instance, if mom had chlamydia and was treated or not treated, or treated and then didn't have a test of cure or did have a test of cure. So we need to know if there was a test of cure, if mom had chlamydia during the pregnancy, okay? And you may be seeing that a lot of OBs don't do the gonorrhea chlamydia testing. We've seen that. It may be that it's a family that they feel is not at risk, not as much at risk. So that may be the case, but there may be cases where maybe they should have done it. Any questions about that? All right. So again, we would culture the eye scrapings. Again, erythromycin does not prevent, erythromycin gel does not prevent it. If they end up having chlamydia conjunctivitis or pneumonia, they get oral erythromycin for 2 weeks. If the mom hasn't been treated, you may ask why we don't immediately treat the infants. Although the infants are at high risk of infection, it's not recommended to treat them because we don't know how efficacious just prophylaxis is. So the treatment at that point may not be helpful until child starts to actually develop the infection. Okay. So usually this is not something we at the hospital, unless we have a kid in the NICU, worry about. But we do need to provide that information to the pediatrician. Any questions about chlamydia?
I have a question.
Yeah.
This is out of curiosity. So have you ever seen C-section mothers that choose not to give their baby's eye ointment develop the infection later?
Not in the NICU.
Okay.
I don't remember. We have had chlamydia and pneumonia in the NICU, but I don't recall if they had refused which wouldn't prevent it. The eye ointment wouldn't do anything to prevent any of this. But we have had cases of chlamydia pneumonia in like a 21, 28-day-old in the NICU. But I have not seen conjunctivitis in a mom who refused. Usually, we don't see those kids at 14 days. We don't. So answer is
is
no,
the choice that is the reasoning behind a C-section mother not getting it because they didn't have a vaginal birth? Is that like, is that just because they're uneducated, or, I mean, the
secretions
chances are less
secretions.
from getting it?
Well, the rupture, the membranes could have been ruptured. What if it was? I guess if they have, I don't know what the statistics are in terms of chlamydial infections in moms who are intact and have an elective cesarean. I don't.
Okay.
I don't think it's zero.
Yeah.
They could eventually get like there could be it could be another way. Maybe someone hadn't washed their hands or mom hadn't washed her hands. I don't know. They could get it another way. But yeah, that's a good question. I still recommend the ointment.
Yeah.
Still recommend the ointment. Because membranes could have ruptured. We don't know. Then the baby may have still been exposed to secretions. So
If they choose, like, do y'all educate them at birth if they say, "Oh, well, I had a C-section, so I don't want to get it"? Like, do y'all educate them so they at least know, or that's just their choice?
No, I take that's their choice, and I don't interrupt their bonding. At that point, the baby's born, and it's like a good moment for them, and I don't interrupt that for, hey, I'm going to educate you about chlamydia and all these bad things that happen. I don't do that.
Okay.
So answer is no.
Okay.
Yeah. So again, as the people who talk to them the first, you guys are kind of the first line to educate them there. So yeah. Herpes. All right. This is not a routine prenatal test. Okay. So herpes simplex in a newborn can happen in 1 in 3,000 to 20,000 live births. Now this is a little bit of a concept to swallow, but in cases where an infant does have an HSV infection, 60% of the time, mom either had a primary like their first lesion ever, or they don't have a history of HSV. Does that make sense? If mom has had herpes in the past and had a lesion at delivery, less than 5% of the time is that the case in a newborn with HSV. So the concept to understand is that a mom who has a new case of HSV during the pregnancy has not had enough time, especially like if they had in the 3rd trimester, they have not had enough time to develop antibodies against HSV to cross through the placenta and protect the baby. Does that make sense? So greater than 75% of neonatal HSV born to women are born to 75% of those who have neonatal HSV have been born to women who are asymptomatic or did not have a history of HSV. And so I need to redo this slide. But the concept to understand is that if mom has a primary lesion, like the first one in pregnancy, that's the time to worry. If they had a lesion like during the delivery. Now, if they had a lesion like 2 weeks ago and they don't have a lesion now, ID still would not test the baby. They have to have a lesion at delivery. Okay. Does it all make sense? That seems jumbled. Point to get across. You worry when it's the first time mom has ever had an infection and it's during the pregnancy, especially if it's at delivery. Okay. If they've had a history of HSV, you worry a little bit less because they have antibodies that have developed and have crossed the placenta to protect the baby. You still worry, but you worry less. You really worry when it's mom's first case of HSV. All right, cold sore or genital lesion, either one. All right. So the reason for no routine screening is because of that, because the cases where it's the most often the case is when it's a primary lesion close to delivery. Okay. So the identification happens when you examine mom, essentially. Most of the far majority of the transmission happens at delivery. The risks are prematurity, fetal scalp monitoring, where you break the water and of course expose the baby to potential secretions, prolonged rupture of membranes. What do? We get surface cultures of their eye, nasopharynx, or rectum, and sometimes umbilicus as well. Keep the rectal sample separate. There's really high suspicion, I have to admit to the NICU and do a CSF culture, blood culture, test the urine, get liver function tests, and go under contact precautions. And this baby would be under acyclovir, at least until the cultures are negative, or if they really do have the infection, then IV for 14 days. If it's ocular, it's PO for 6 months. And that results, that basically, we're protecting the baby's neurodevelopment by treating for that long. Okay. Any questions for that? So it's really important to know all this. Okay. This is a little jumbly, but basically this is a new HSV algorithm, which basically delineates, we would only pursue diagnostic testing in the baby if mom had a lesion at delivery, whether it be vaginal or cesarean. I would still test the baby, even if like the mom had intact membranes and was delivered by cesarean, if she had a vaginal or oral lesion, any visible lesion. Okay. So that's basic. So just know if mom has a lesion, that's really important. So this is what kind of the HSV lesion look like in a newborn. They're like, these are ulcerated ones. But you would also see vesicles, kind of like chickenpox vesicles. Any questions about HSV?
Dr. Lee, for a baby, do they typically present on the trunk, or can they be anywhere, these lesions?
They can be anywhere. I think they can be anywhere.
Okay.
They can be anywhere. All right. Tuberculosis, we don't see this very much. It's usually, the transmission is usually postnatal through air droplets, just like COVID, the mucous membranes. There can be congenital TB though. It can be crossed through the placenta and cause congenital issues in the baby. Neonates are at much higher risk of disseminated disease, and it can result in not just pneumonia or respiratory distress, but also hepatosplenomegaly, lymphadenopathy, et cetera. And tuberculin skin test just is a PPD. The specific test that I've never used, that I think it came out after I finished school. A quantiferon test, which tests for interferon gamma, that secretion that is from T cells that is specific for TB. Okay. So that's more a specific test. You may see a positive tuberculin skin test, a PPD, in a mom who has received the Bacille Calmette-Guerin BCG vaccine against TB. In an asymptomatic neonate with a mom with a positive PPD, here are the cases. So asymptomatic neonate, mom with a positive PPD. Mom has a normal, right? Need to separate breastfeeding, right? It's an normal. And can monitor active or not. So that case need to diagnostic reason mom. Okay. Active, the baby, so mom, this regimen, isomethambin, FM, vitamin B6, and that mom needs to be treated for 9 months. If the infant has if the mom has active disease, what do we do with the infant? We give isoniazid for 3 to 4 months. So this is another case in which the baby needs the medicine at the bedside prior to discharge. Okay. I don't know if anybody assists like in the case of an HIV meds, but this baby also needs meds. Congenital TB, like I said, could also happen. In that case, that's really rare. So I would have to get an infectious disease consult and probably start the kid on a multi-drug regimen with isoniazid, rifampin, pyrimethamine, and an aminoglycoside antibiotic, and maybe steroids if the baby has meningitis. Any questions about TB? So I would probably take a screenshot of the part under asymptomatic neonate with a mom with a positive PPD in those cases, okay? If mom has a normal x-ray, which happens most often, no separation, breastfeeding's okay. Abnormal x-ray, separate the infant and confirm with active disease. Active disease, start treating the mom. I think there was one question previously, how long is it until you can not separate them? Like how long after treatment can you let the mom room with the baby? I think it's 24 to 48 hours of treatment. I would have to look that up again. But I think when mom has had appropriate treatment, we can start to they can start to room again. Okay. Isoniazid has no adverse effects in breastfeeding. Okay, after infant receives isoniazid, no separation needed until, okay. After infant receives isoniazid, no separation is needed until unless there's multi-drug resistant TB or mom has poor compliance. Express breast milk can be given unless there's tuberculosis mastitis. Okay, breastfeeding. Any questions on TB? Any further questions on TB? All right. Breastfeeding contraindications, at least in the US. Maternal HIV, HSV lesions on the breast, presumed active TB, TB mastitis, a breast abscess, and the last point is not definitive contraindications, but you should be careful in cases of maternal oral HSV lesions. If mom is CMV positive and baby is very low birth weight, that's more of a thing to worry about for us in the NICU. Okay. Zika, we haven't seen this in a while, but we all know that the baby can present with microcephaly, ventriculomegaly, brain calcifications, cerebellar hypoplasia, optic nerve dysplasia. If it's suspected, we get a Zika RNA PCR in the baby as well as the IgM level. We'll get a head ultrasound. They'll get an eye exam in a month. We have to report it to our local health department. The genetics and neuro should be involved for the baby as an outpatient. Then the only real thing we can do is assist the baby in neurodevelopmentally with early intervention. All right. This is actually the last thing that was missed, resulting in some harm to a baby. And there was a safety always on this. So maternal thyroid disease. I think a lot of the time, people just kind of assume that it was related to the pregnancy. It's not always. No, this could have been a pre-existing thyroid disorder in the mom, specifically Graves' disease. When mom has Graves' disease, 1 in 50,000 infants is affected. And what happens? There's transplacental passage of antibodies. This is autoimmune. So mom has created antibodies against her own thyroid, and these antibodies actually activate her thyroid or block it, but mostly activate it. So these are the people who develop the sequela that you hear about in hyperthyroidism, like eyes are popping out, thinning hair, they're really thin, okay? Things like that. So this is the case. So in this case, what do? You ask, has the mom had a thyroidectomy? Because that's what happens with Graves, or a thyroid ablation, or a radioactive thyroid ablation. Even if that has happened, even if mom has had those things to help with her Graves, she still has the antibodies in her body. Her body is still creating them. And these antibodies can pass to the fetus and activate the baby's thyroid, or block it, but usually activate it. This can present in utero, and the baby could develop high output heart failure. And it can present up to 4 to 6 weeks after delivery. Okay, so if mom is on propylthiouracil uracil, PTU, or methimazole, those are thyroid blocking medications that can suppress the symptoms in the baby. Okay, so what is a really simple thing that we can do? We can get cord blood for thyrotropin receptor antibody. We can just get the cord blood, and if it's negative, it has 100% negative predictive value. What does that mean? It means if the thyrotropin receptor antibody is negative in the cord blood, we can 100% rule it out in the baby. Isn't that useful? Really useful. Often, it's one of us, the neonatologist, has to catch that, like when we come to the delivery. Oh, this mom has thyroid disease. Is it Graves or is it Hashimoto's? Hashimoto's is fine. It's Graves that we worry about. And lo and behold, the mom says, oh, yes, it's Graves. And nobody in the room knew or thought to communicate that to me. And I have to say, hey, okay, we have to get the microtainers or the vials for the thyrotropin receptor antibody. So we end up catching it. Last case, this baby was already born and was like 8 hours old. And I usually go through all the history, the maternal history of each mom of our nursery babies the night before I round in the morning. And I caught this. And lo and behold, we had to get the blood from the baby. So the baby had to get 4 vials of blood or something. Okay, we had to stick this baby for 4 vials of blood. We didn't have to do that. We could have gotten from the cord, and the baby wouldn't have to be stuck for that. So that was a pet peeve. That was very, very upsetting to me. So this is something that we have to know. We can prepare for this. You know, we can just rule this thing out with the cord blood without having to harm the baby. Any questions about that? Okay. So again, what is the big deal for the baby? If the baby has these thyroid stimulating antibodies, kid goes home, starts having tachycardia, and then eventually high output heart failure at home, that's not good, right? So if we can have this information, pass it on to the pediatrician to monitor for this, the kid could be started on like a beta blocker or something at home, right? So there's my spiel on that. Maternal lupus, kind of a similar concept. So in this case, if mom has lupus or Sjogren's, which we had recently, you ask the mom, do you know if you had SSA or SSB or anti-Ro or anti-LA antibodies? Sometimes these are right in Epic, and we can see whether or not they had them or not. What is the big deal with them? Well, SSA and SSB antibodies can cross the placenta and attack the cardiac conduction system of the heart with permanent effects. This can result in congenital heart block. This is why we get an EKG to rule that out. This may be actually the first sign of maternal lupus. Maybe mom hasn't even been diagnosed with lupus, and somebody listens to the heart and realizes, oh my gosh, this baby is pink and crying and stable, but the heart rate's like 80 or something, or 70 or 60. That may actually be this first sign of maternal lupus. It can result in other things: a rash in the baby, elevated liver function tests, cytopenias can affect the bone marrow, cholestasis, encephalopathy, or high drops from heart failure in utero. Any questions? Any final questions? That's it. That's all I have. Anybody? All right. Well, I hope I have demonstrated why prenatal history is so important. On days that I'm working, I do review all the maternal charts of all the babies prior to my morning round. But you should not depend on that. Not everybody does take that time. Okay. And maybe there's something that that I don't know, that I can't glean from Epic. That's how I review. Like I don't go to the nursing station to review all the maternal paper charts. So you are the first line of defense. You are the ones directly getting sign out from the L&D nurse, and really L&D is the first line of defense. So I hope we can distribute this to them as well. Yeah.
I have one thing just about prenatal care in general.
Yeah.
What are the appropriate amount or the total number of prenatal visits that is like acceptable? I thought it was 4 to 5, but then Dr. Goldberg said for this one patient, 3 was enough. All her history was negative. So is there like a specific amount of prenatal visits that y'all look at?
To me, if it's